Hello, everyone. I'm Pamela Brewer, welcoming you to this edition of M.E.S.H. M.E.S.H is the place where your mental, emotional, and social health is always on the agenda. And today we're going to be talking about something that, well, let me say a couple of things about it. We're going to be talking about something that people hear about a lot, but we're also going to be talking about something that people do not hear about enough, and that is dementia. A dementia diagnosis is something that scares people. People may run away from it, and lots of people don't understand it at all. So I'm really happy to introduce you to Julia Wood. Julia Wood is with the Lewy Body Dementia Association. Julia, welcome.
Well, thank you so much, Dr. Brewer, for having me. It's an honor.
Well, you heard me say that dementia is something that we hear about a lot, and yet we don't know enough about. And the reason that I'm talking to you today specifically about Lewy body dementia is because, from my perspective, when people hear dementia, Alzheimer's, for folks, those are interchangeable terms. And my understanding of Lewy body is that it is the second most common dementia diagnosis that nobody's ever heard of. So help us with that.
Absolutely. And such great points to make. So I think, even though there's been a lot of work done over the past, I would say almost decade by, the National Institutes of Aging and other organizations to really start to acknowledge that there's Alzheimer's and other related forms of dementia. I think still for most people, like you said, Alzheimer's and when we hear the word dementia, people automatically assume that it's going to present like Alzheimer's, which we really think about those memory changes, kind of that amnestic type presentation of not remembering family members' names or events in your life. And Lewy body dementia is actually almost opposite from this. It's very, very different. It affects more aspects of attention and so then things like executive function, so doing tasks that involve more steps, requiring attention to follow a recipe or pay your bills, things like that start to be affected more for people with Lewy body dementia, and also visuospatial function. So they start to have issues with the brain processing space with their vision. So very different profile if you look at the two of them side by side and how it affects thinking and aspects of that. Alzheimer's and Lewy body dementia couldn't be more different.
So that's really interesting. Let me back up a little bit. The overarching category is dementia. Is that correct?
Yes, that is
Okay.
correct.
All right. And then Alzheimer's is one of the types of dementia that people can experience.
Yeah.
Look, what's your sense of how it is that Lewy body is, in the scheme of things, so commonly diagnosed, but people don't know what you're talking about?
Yeah, it's actually very often misdiagnosed, and we believe that's led to part of the problem as well. And also, unfortunately, we still hear. I was recently at a small conference in Wisconsin, and there were people there that had been told, even when they saw a doctor, it doesn't matter what type of dementia you have. It doesn't matter because there's nothing we can do about it. And that's actually not true. There are a lot of things we can do about it. And there are a lot of things we can do wrong and that aren't helpful and very, very specific to how we approach both medical management of Alzheimer's versus dementia or Lewy body dementia, and also even those non-pharmacological strategies. If you think of someone having memory problems versus someone having attention problems or vision problems, that's going to be two different approaches of how you look at like their daily task. Because in all transparency, I'm an occupational therapist, and so my background was in working with these clients and how to help them find workarounds to really keep them engaged in their life. And I found immediately that it was completely night and day working with someone with Alzheimer's versus someone with Lewy body dementia. And both, there's a lot you can do to help, but it's just you really need to understand the conditions and also understand the individual in order to make those strategies most effective.
So again, I want to back up a little bit because I know there are folks who are sort of scratching their heads. Is there a cure currently
Mm.
for dementia in general, for Lewy body in particular?
No, unfortunately, at this time, there's no cure for any of the dementias, and in fact, we don't really see a lot of reversing a lot of times those cognitive changes. There are some treatments, both in Alzheimer's and some in Lewy, that are looking promising for possibly helping to slow the progression and maybe make some changes, but we still need a lot more research. and a lot more studies to be done on those. So right now there's no cure. And even with Lewy body dementia, most of the medications are off label. So there aren't medications specifically indicated for a lot of the different symptoms. So they have to kind of borrow medications to treat like the autonomic symptoms or the sleep symptoms from other conditions. So it's very difficult to get diagnosed, and it's also very difficult to manage medically, even for seasoned healthcare providers that really understand the disease.
So let me ask you this. You've just gotten how do you know? I mean, you're saying that it's really hard to diagnose. Is there a age or a gender or a sort of, list of symptoms, if you will, that says to you, "Oh, this might be Lewy body. Let me go talk to a doctor."
Absolutely. That's a great question. So the symptoms are very different, as we talked about. And so there's some checklists out there. We have a couple on our website. One is called our comprehensive symptom checklist. That's for families. And so you're going through and kind of ticking the boxes that match up so you can have that informed conversation with your medical provider. We also have one for clinicians that has the diagnostic criteria on the back end. So it helps them kind of walk through the steps of diagnosing someone. There's also a great screening tool out there developed by Dr. Jim Galvin at the University of Miami called the Lewy Body Composite Risk Score. And I believe it's like 10 items or so that you can kind of check as a screening measure to see if someone's leaning more that way. But then also a neuropsychological evaluation often can be very helpful because when a seasoned neuropsychologist gets in there and does, rather than just doing that global measure, because we have a great slide by one of our researchers in Mayo where they compared how people did in different cognitive tests with Alzheimer's and with Lewy. And what's fascinating is if you're doing just like a general screening, like a dementia rating scale or a MoCA, a lot of times they don't look different. It's when that neuropsychologist gets into those different elements that a lot of times it will tease out. And then also some of the more psychiatric type features, hallucinations, delusions. There are also sleep symptoms. So often people have REM sleep behavior disorder many, many years prior to symptoms where they'll violently act out their dreams. So there's things they can look at other than just the cognitive profile to help make that diagnosis through those checklists and through those exams.
Is this something that runs in families?
At this point, that's a really great question. At this point, there's nothing to say yes as far as like genetics, but interestingly, we do have an amazing former care partner out in California who had a father, a sister, and a brother who have all had Lewy body dementia.
Interesting.
So at this point, we don't have anything that points and says, yes, there's this gene that predisposes this, but we are seeing some families sometimes that have this profile. But another thing I think that's fascinating is a lot of the research in Parkinson's, which is a Lewy body disease, is indicating that there's some environmental toxins, teratogens, air pollution, things like this that might be linked. So a family could have the same exposure, when you think about that, to some of those things. So I think we still need to learn a lot more about the genetics. And I know in Parkinson's, they're learning more and more.
Yeah.
And also about some of these environmental factors and some of these toxic chemicals that might be influencing this as well.
So what's interesting is it kind of sounds like it's a yes and no but response, which is
Yeah,
really complicated for clinicians as
yeah.
well as for individuals. Is there an age? So many people think, "Oh, I forgot my keys. I forgot my keys 2 days in a row. I've got Alzheimer's. I'm scared. I'm not going anywhere." Is there an age range? Are there You've talked about some of the symptomatic changes. Is there
Mhm.
an age range? Is there a gender predisposition, if you will, to Lewy body?
Really good question. We do see that we have more males who are diagnosed with Lewy body dementia. But interestingly, there's been some research done by an amazing woman named Edna Bayram at the University of Colorado,
Mm,
who, like we're seeing with a lot of neurological conditions, there's differences in how women present than men. So do we maybe sometimes miss those women and maybe they're going diagnosed less frequently? We're not sure. But definitely men seem to be diagnosed more often. As far as age, it tends to be if it's under 50, we're really considering that on the younger end of the spectrum. This tends to be more of like FTD, frontotemporal dementia, happens much earlier on. This tends to be a little bit later in life. but we do have people in our community, unfortunately, they're in their 30s and 40s now that are being diagnosed with this. So that's considered kind of young onset, like with Parkinson's, that's also considered a younger onset, but
Absolutely.
it happens. So I think definitely a later in life dementia commonly or typically, but definitely can affect people younger as well.
So in some ways, I mean, there's a lot of good news in that research is occurring.
Yes.
There's some troublesome news because there's still so much that we don't know,
Yes.
particularly about something that for which there's no cure. If you have it, you have it. But what you're talking about, I think, is that there can be a quality of life that is enhanced, assuming that you have information about what exactly kind of dementia it is that you're dealing with.
Absolutely. Well said. Well said. And, you know, I talked a little bit about some of the, you know, pharmacological research, genetics, things like that, but also there's an amazing study coming out of Rush University called Persevere, which is a peer mentor program for care partners because it's such a difficult journey to walk. And like you said, you need resources, you need education. So what Dr. Jory Fleischer and her team have done is really put all these resources and education together and then paired up a mentor and mentee. So a lot of times this might be a former care partner supporting now a newer care partner in their journey, and she's had tremendous results from it. Because I think that so much of it is you know people because there are less resources, it's less known. There are cognitive fluctuations too. So with Louis, somebody might look great 1 minute. So they go to the doctor or family comes over and we call it showtime. All of a sudden they're just great and ready to go.
Right.
And then later the care partner's like, now they're completely zoned out and you know, it's like they're incoherent. And that's very different from Alzheimer's as well. And that can really confuse family because the adult children come over and go, Dad looks great. I don't know what you're talking about. Right. So I think that peer support we're seeing is really, really important. That access to resources so crucial for families to be able to get their footing and go, what's next? Or how can I support the aspects of my quality of life that I want and need to? So, very good question.
You know, you're bringing up the issue of caregivers, and
Yes.
caregivers have their own journey to walk, I would suggest. Not knowing, okay, what do you do with not knowing? What do you do with when to know? What do you do with when to ask the questions? What do you do with the symptoms? What do you do about asking for support? So this program that you're talking about sounds really exciting.
Absolutely. And I think it's so necessary because you bring up such an excellent point that I didn't mention, Dr. Brewer, is that for so, you know, where Alzheimer's has stages, we don't even have that with Lewy body dementia. It's such an individual presentation. Like we had a saying in my clinic that if you've seen one person with Lewy, you've seen one person with Lewy, or, you know, the Lewy people with Lewy are like snowflakes. They're all, you know, in their own unique flavor. So we unfortunately we have kind of a range of span of life, but still some people live way longer than that. Some people might not live as long, but we don't have anything to really predict. Like if X, Y, or Z is happening, you've got this many years or you're at this stage. And that is so frustrating for families because you feel, you know, there's this nebulous, like what's next? What am I preparing for? And even the doctors a lot of times don't know and can't tell.
You are referencing doctors, and certainly, I mean, I've had situations where I've talked to clinicians, not just about dementia, but just sort of any kind of illness in which it is seen to be terminal. And I can't tell you the number of times I've heard clinicians say, "There's nothing I can do about it. There's really not a whole lot to say because there's nothing to be done." So for those people who are listening who are clinicians, and certainly there's a half a thousand different kinds, what would you like for them to think about in terms of Lewy body?
That's a beautiful question. And you're hitting on a passion point for me for sure. I always say it takes a village. And one thing that I was really, really blessed to experience within my clinical care, I started out with my field work and my clinicals at Mayo, very team-based, very interdisciplinary. Landed at the University of Pennsylvania, still the same idea. I'm actually faculty for a program called the ALET or the Team Training Program for the Parkinson's Foundation because you need it's more than just a doctor, right? And I think that sometimes we have to educate families around this and clinicians because there's still what I call the little house on the prairie mentality, where we think the doctor shows up and takes care of everyone in the family and even delivers the calf on the way out the door, you know? And it's like our healthcare system is very different. And so we need social work involved when possible to help you find those resources, get that support, make those plans. Occupational therapists, I work so much with families on understanding the disease, finding those workarounds, how to support someone to remain as independent as possible, as long as possible. Physical therapy, we haven't talked much about the mobility challenges, but with that relationship to Parkinson's come a lot of issues with falls, difficulty walking, difficulty moving. And so PTs are really helpful. And then even speech language pathologists, because of some of the communication challenges, issues with swallowing, and even aspiration, where you can get a pneumonia with that. So I encourage people to really, if your doctor doesn't have a team, maybe you don't have that established kind of interprofessional clinic, I encourage you to work to build your own. And I know that can be hard, but I met a wonderful woman at our recent conference, and she's like, I live in a rural area of Kentucky, and I've watched your webinars where you talk about palliative care and all these things, and I don't have any of that. But she said, what I decided to do is I'm going to go find those pieces of it. She's like, I was having trouble with my walking. She's like, I looked around, I found a physical therapist, and I had these other issues. And so I found a social worker and talked to them. And sometimes going to support groups. And we have an amazing network with the Lewy Body Dementia Association of virtual support groups and in-person support groups throughout the country. And that's sometimes where you find your best resources, right? In those areas. They went to that PT that was great, or they went to that counselor or that psychologist that was really helpful.
Absolutely.
So I encourage people, ask your doctor for those resources. Hope that, and I hope for the clinicians out there, you'll hear me, that like build your network, build up those people in your area so you have those referral sources. But if your doctor doesn't do that, sometimes we got to self-advocate and find those resources. And we'll help too. Call us up at LBDA.
I just about to say, speaking of resources, in the few moments that we have left, can you tell us where to go to get more resources? It sounds like your organization offers a huge resource base. Where can we go?
Absolutely. So you can start at our website, lbda.org. And then if you want to reach our support services line, you can email support@lbda.org, or you can call 1-800-539-9767. So keep in mind, this is a support line. It's not a hotline. We believe our social workers and our clinicians who manage that line need to sleep too. So they'll call you back if you call overnight. But they're really, I think, the best gateway into the resources our organization has, because what they so beautifully do is, let's say you call up as a care partner and you're like, we need to find a home health aide, and I'm not sure about my insurance coverage, and my husband's having falls. What should we do? A lot of times they can curate the resources that we have in-house. If we have webinars that are helpful, or handouts, or courses on our Louis Learning Center, or different people in our networks that they're aware of, or different home care agencies, and they can really curate and custom that package to meet your needs, and kind of, and then they're always there if as your needs change, because of course they will over time. But I think they do such a beautiful job of really helping to route people to what's most helpful for them at LBDA, so you don't have to go on and try to dig around and find it yourself. We've got a lot.
It sounds like it. So the first stop, just before I run away, the first stop is lbda.org.
O-R-G. Yep.
Terrific. Julia Wood, thank you so much. You are with the Lewy Body Dementia. You've certainly given us a great deal to think about. I may even try to get you back to talk to us a little bit more. But for now, you've really, I think, broadened our perspective about Lewy body, what it is and what it isn't. And I thank you very much for your time today.
Oh, I thank you so much for the opportunity to meet with you and also with your network. Thank you so much.
And folks, thank you again for joining us today on this edition of M.E.S.H. As you know, M.E.S.H. is with us every week. I'm with you every week. I hope that you will share this program with someone you care about, and I'm hoping that I'll see you next week. Take care.